Hello guys, so hope you're all okay. You're all enjoying your life and welcome back to Dr. Arshad Nadeem Awan ultrasound and radiology teaching videos. Today I'm going to particularly talk about soft tissue masses, the one very common and you come across almost about 60% radiology investigation is based upon this small tumor, this small soft tissue lesion that is called as lipoma. Lipoma is actually a benign lesion, but at times it may convert into liposarcoma, and if we miss the diagnosis, we put the patient's life at jeopardize. We jeopardize the patient life. Before going to start about the lipoma and the liposarcoma, that we can pick on the ultrasound imaging and that which criteria is for the lipoma and liposarcoma on the MRI, especially T1, T2 and fat saturated images. I would say here, thanks to iStylo, this beautiful blazer which I am wearing, that is from the iStylo, and this video is specially sponsored by iStylo. Down there is a link, so you must go there and look for different stuff. It's offering beautiful cardigans, beautiful blazers, some electronics as well, and jewelry. So it's worth buying from the iStylo. So thank you very much, iStylo. So now I will come to the point of the lipoma. Lipoma, when you're doing ultrasound, and on the ultrasound it has a very particular appearance. If it is small in size, it appears to be hyperechoic with the hyper-echogenic striation inside, and if it is large enough, so it will appear as slightly hypoechoic, not hypoechoic, but you can call it as an isoechoic. It will not be as echogenic as the small lipoma happens to be. And the second important thing is you have to pay attention for the striation. At times it may convert into carcinomatous changes, it may develop carcinomatous changes, so you never know. You might just miss that and you label that is a lipoma, and you have to pay attention. So what are the criteria for, and how you will think, and what the suspicion would be raised if there is any cancerous changes? The first very important thing is the size. If it is growing bigger and bigger, it's mean that there is some malignant potential in it. The second thing is that the fat saturation is completed or not. On the MRI scanning, especially T1, T2 fat saturated images and contrast imaging, you have to look whether this fat saturation has been completed or not. The second thing is there any other components other than the fatty tissues, like if there is soft tissue components within the lesion, which you can also pick on the ultrasound as well. So this unusual appearance will start ringing the bells, and you might think about the malignant changes. The third very important criteria which you can also estimate on the ultrasound as well, that is the thick striation. The striation should be less than 2 millimeter. If you can find and you see that there is a thick echogenic striation and unusually this appearance looks to you, so you must think of the liposarcoma. And the third thing is, which some of researchers says that it may be or may not be, but still it goes in the favor of the liposarcoma, that is the calcification. If you come across any calcification, either ultrasonographically or on the MRI, look for the liposarcoma and advise histopathology to confirm all these things. How it will appear on the ultrasound imaging, lipoma and liposarcoma, how it will appear on the MR images, how you will look for all that. So all these information has been included in this video. So let's start watching this video. As I mentioned in the introduction, that the soft tissue tumor, benign lipomatous tumor, representing almost 50% of soft tissue masses, it happens to be made up of adipose tissues. Sometimes it will be surrounded by the capsule, sometimes there is no capsule at all. In that condition, it would be termed as a lipomatosis. It happens to be subcutaneously, but it may involve the muscles, intramuscular, it appears, and also within the bone, and at that case it would be an intraosseous lipoma. This is an example of intraosseous lipoma, It is metaphyseal lesion. It is mostly lytic lesion with sclerotic surrounding margins, slightly irregular, and in the center you can still appreciate some soft tissue with thick septations. However, this thick septations applies on the carcinomatous form, but I will explain it in the subsequent images. This is a classical example of the lipoma, and it will appear lytic, surrounded by sclerotic margins. Another example of the intraosseous lipoma, a typical lytic lesion. It's involving metaphyseal area, metaphysis of the long bone, and with a sclerotic rim. You can appreciate the sclerotic margins around. This is typical lipoma. So whenever there is differentials of the lytic lesion surrounded by the sclerosis, always include the lipoma. Very important place for the intraosseous lipoma is the calcaneum. Here in this calcaneum you can appreciate a well-defined lytic lesion surrounded by sclerosis. So this is a surrounded sclerotic lytic lesion involving the calcaneum. So calcaneum is a very common part and of the occurrence of the lipoma. So whenever you come across any lytic lesion in the calcaneum, in your differential must include the lipoma. It will be typical lytic lesion. So another example for the better understanding, this is calcaneum, and on the calcaneum again you can appreciate a well-defined lytic lesion with sclerotic margin. So sclerotic margin is one of the important feature of the lipoma, and sometime there will be thin septation, and if there is any calcification within the lesion, so it will make it a bit complex, so you can think of malignant deformation. Lipoma has also the potential to convert into malignant degenerative changes, malignant transformation, and there are multiple types of the liposarcomas. It could be atypical, or it will also be called as well differentiated liposarcoma. It may be undifferentiated liposarcoma, and it may be myxoid liposarcoma. Keeping in view the certain characteristic features which can be seen in the liposarcomatous changes is one of the MRI features. The first important feature is that it should be similar to SQ FAT on any imaging modality, like in continuous sequence. If there is changes in the sequences or in the appearance or the intensity, you may think of liposarcoma. Here on these images you can see there are multiple slices available, simple radiograph and MR scanning, and this MR shows that it is liposarcoma. The another important feature is which can cause suspicion is the size. If it is greater than 10 centimeter, you can think of liposarcomatous changes. The third important feature is that the septa, there will be internal septation which can be visible on the CT, MR, and the ultrasound. The criteria for the septation is it should have been less than 2 millimeter. If the septa appears thick, so you can consider the malignant transformation. So it is usually seen in liposarcomatous changes. Here on this MR image you can see that the size of the lesion is increased and enlarged, so there is a suspicion of the liposarcomatous changes. Liposarcoma or simple sarcoma can be complicated either by infarction or if there is intralesional hemorrhage, and the third criteria, if there is mineralization, if there is calcification, so this will be considered as a liposarcomatous condition. The third important thing is, so far the retroperitoneal fatty mass is concerned. Retroperitoneal fatty mass should always be considered with suspicion and should always be think of malignant transformation. Whenever you come across with any mass having the fat and it is enlarged in size and it's having a mineralization, even without the mineralization, on the basis of simple fatty presence, you can still consider this would be a malignant case and malignant transformation, and liposarcoma should be in your differential and should be done further workup immediately to rule out the presence of the malignant cells for the further management.